Good morning, everybody. And I'm Nona Baker. I am co-chair of MPN Voice, and I extend a very warm welcome to everybody in Ireland, the Irish clinicians, and everybody who's made this possible. I'd also like to highlight at the moment, we have attendees from Norway, Finland, Taiwan, New Zealand, and California, which is an incredible thing for MPN Voice. There are other people to thank. There are the clinicians, Eibhlin Conneally, Clodagh Keohane, Natasha Leby, our patient speaker, Mary Kelly, and Roger Preston, and also Maz, who's helped put all this together, and not forgetting Danny Palmer, the commercial service directorate at Guy's and St Thomas's Foundation.
Die vrouw is aan het praten en ik versta het niet.
Sorry? Hello?
Carry on, Nona, don't worry.
Okay. Who has been immensely helpful to us in putting this forum on. And finally, to Novartis, who have helped sponsor this and made it possible. Next slide, please. Just a little bit of housekeeping here. Just please ensure your first and last name is showing to help us move you into the right breakout group. Instructions will be posted in the chat. Now, this is really important. This meeting is being recorded, excluding the breakouts. If you do not wish your face to be shown on the video and uploaded onto YouTube, please turn your camera off during the talks. There is still a chance to submit your questions to the panel. Please use the chat function to send your questions at any time during the event, and we will do our best to answer as many as possible. We can't answer any questions about your personalized treatment plans. Please refer back to your consultant. It would be really helpful for you, please, to remain on mute during the talks and when you are not speaking during the breakout session. The other useful thing you could do for us, please could you fill out the feedback survey? MPN Voice are constantly updating and trying to meet the needs of the patient community with these forums. So your feedback is really useful to us. Thank you. We've got a very busy agenda this morning. For those of you who haven't seen it, here it is on the screen, but I thank the clinicians who are taking part. And we will press ahead with the meeting. Now, some of you, and particularly the new people who've joined today for the very first time, perhaps don't know very much about MPN Voice. Some of you have seen these before. What I would encourage everybody to do is to keep checking our website, mpnvoice.org.uk. That is always full of up-to-date information. We started in a very small way in 2003 under the guise of Claire Harrison at Guy's, actually it was at St Thomas's then, and it was a small group of patients, hematologists, specialists, nurses, and psychologists. We became MPD in 2011 and MPN Voice in 2013. That was as a result of the World Health Organization making MPNs a cancer neoplasm. We work under the umbrella of Guy's and St Thomas's charity. Guy's is on the left, St Thomas's is on the right. And that is why we find it incredibly helpful, because they are so supportive to the MPN community. Our structure here, we had to, when COVID arose, we really had to get our act together because we could no longer take our forums on the road. And so we structured our charity in a very concise way. You will see at the top, I'm co-chair with John Matthias, and then we have Tim and Claire Harrison on the executive committee. All three of us on the executive committee are actually patients, MPN patients ourselves. Coronavirus, my goodness, has that hit everybody? And I would actually say a huge thank you to the clinicians giving up their spare time to be with us today, because I know just how hard it's been for you as clinicians, and particularly in Ireland when you lost your internet or service in the hospitals. We've done a lot of work during the coronavirus pandemic. We can consistently update the website and Health Unlocked and Facebook as situation changes, and therefore ensuring the community has accurate information at all times. You know, again, we have included having representatives on Cancer 52 consortium of cancer organisations. MPN Voice continues to deliver these virtual forums, but one thing I would say, and that's to be remembered in all the presentations today, you know, every single country has a different health authority and different health provisions, but the one thing that is common here is that as patients, we have we need emotional and physical and educational support on MPNs, and that is universal. The other thing that we do is provide up-to-date information, and that's one of the reasons we started MPN was, and certainly when I was diagnosed in 1990, there was absolutely no reliable information to be had. And so now we're constantly updating our booklets, our YouTube channel. We now have somebody specifically who does, a patient actually, who does our social media. Health Unlocked. Health Unlocked is an interesting one because I'll let you into a secret there. It is actually monitored by doctors. Anything that isn't accurate comes down, and therefore we are ensuring that we are delivering best practice and accurate information on every post that goes out. The forums, you will see that we're growing with these forums, because I think the patient community, as we've seen this morning, you know, we're seeing people from all around the world joining in now. When Maz and I took the patient forums on the road, gradually we were building up the numbers, but we are now increasing the numbers of virtual forums. Again, always on our website, you will see when there will be a forum. But the most exciting thing for the Irish community is that the first forum that we are planning to be back in person again will be in Galway. And that will be on the 21st of May next year. So hopefully we will see the Irish community there in Galway. The MPN Voice virtual forums have been attended, and I say attended, by people all around the world. And the videos have now been viewed a staggering total of 15,991 times. And they're all available on the MPN Voice YouTube channel. And I really do recommend you check into some of the doctors' presentations on those forums, because I'm sure many of you will find them extremely helpful. We do a lot of research and help fund it and work in collaboration. I'm not going to talk too much about that now, because that's part of the presentations today. This is another ongoing research project that we're doing, and the studies for that will be known soon. MOSAICC. This is the most exciting project from a patient's perspective, because it's an epidemiology study of why did we get it. And I'm not going to talk about that because Dr. Keohane is going to be talking about that. But what I would say is we're really excited to see that the Irish hospitals are going soon to be open to be participating in this study. The coronavirus, you see, again, it's different in each country, but we have published the vaccine effectiveness, and it was done on the study of the Pfizer vaccine in MPN patients. Advocacy, this is something that's growing, and this is where we have a patient voice with drug companies in the MPN community, and make submissions in our country to NICE for drugs to be used. Now, this is also key. We couldn't exist without our fundraising. And I have to say that last year, when we did a patient forum in Ireland, we had the most amazing response from the Irish community. And Maella organized the most fantastic concert that raised 3,000 euros. And we're always grateful for any support, because as you can see, these projects that we're doing, the treatment for research, do cost money. And we're also grateful to the pharma companies for their support as well. The fundraising, but you know, Maz and I were talking the other day, because we're going to Galway and because we're now collaborating in Ireland with another research project. It would be great if there's anyone out there in your community who would like to join our fundraising team. And I can assure you it's fun. It can be, you know, just a knitting circle, or it can be anything that promotes MPN Voice. And you will see there's all sorts of different pictures there of people having a lot of fun raising money for MPN Voice. If you would like to donate, please, you can donate through the website. And if you've got any queries, please email Maz, and the email link is there. Thank you so much for your support. And I'm really looking forward to hearing these talks today. I think we will all find them most useful and interesting. Thank you. I'm now going to introduce Dr Eibhlin Conneally, who we've known for a long time, and she's going to talk about the overview of MPNs and treatment and COVID vaccine data update for Ireland. Welcome, Eibhlin, and thank you for your help.
Eibhlin, you're just on mute, actually.
Apologies. Good morning, everybody, and thank you very much for joining us early on a Saturday morning. This is a fairly ambitious title to cover in 15 minutes, so it really will be a whip through. And as Nana has already said, if anybody has questions, we can put them through on the chat, or they probably can be things that we can discuss more in the breakout groups. Okay, so what are we talking about when we're talking about myeloproliferative neoplasms? The ones that we're really talking about today are polycythemia vera, essential thrombocytosis, and primary myelofibrosis. So what are these conditions? So we define them as clonal disorders, and that basically means that it starts off from one cell, and ultimately that cell divides, and in the bone marrow we ultimately end up with too many cells in one or more of the blood cell types, either the red cells or the platelets, and sometimes indeed the white cell count. These are rare disorders. On average, there's 1 to 2 cases per 100,000 per year. But because people live with these disorders for a long time, there are many people with these disorders in Ireland. And in terms of making a diagnosis, it requires a combination of your story and what we find when we examine you. It depends on your blood and your bone marrow examination. So what do we see when we look down the microscope? And increasingly, on other laboratory tests, including molecular tests. Next slide. So the field of myeloproliferative neoplasms, you know, we've known about these disorders for probably about 100 years, but what really has changed the field in the last 15 to 20 years are the discovery of these, what we call mutations, and they're basically proteins within the blood cells that are changed or work differently, and they result in the increased mature myeloid cells. So the first of these genes that was described was the JAK2 gene in 2005, the MPL gene, which is the receptor for another protein, in 2008, and the CALR gene in 2013. And these have absolutely revolutionized our understanding of these disorders. And next slide, and I'll show how these, we think these abnormal genes make a difference. So in our cells, this is a cell membrane, and there are proteins on the surface of the cells that basically take messages from outside the cell and bring them into the nucleus and tell the cell what to do. So this is the erythropoietin receptor, and there are this protein, the JAK2 protein. This receptor at the moment is not activated because there's no erythropoietin, so there's no signal going into the nucleus. Next slide. When erythropoietin binds to this receptor, it changes the receptor, and it basically...
Eibhlin, you've just put yourself on mute again.
Sorry.
No problem.
So when the erythropoietin binds to the protein, it changes how the protein works, and then it sends signals to the nucleus. Sorry, next slide. So that's where the proteins get activated. Next slide. And then the downstream proteins get activated. And then in the next cartoon, when we have the change in the JAK2 protein. So it doesn't need this protein on the outside of the cell, and this activation is happening much, much more strongly. And even in patients who don't have the JAK2 mutation, both the CalOR mutation and the MPL mutation also activate this pathway, and this ultimately drives the increased production of blood cells in the bone marrow. Next slide. So in patients who have polycythemia vera, virtually everybody has the JAK2 mutation, probably over 95% have an abnormal JAK2 protein. In some patients, they don't have the classical JAK2 abnormality, but they have other changes in the JAK2 gene. In essential thrombocytosis, it's a bit more mixed. About 2/3 of people will have the JAK2 abnormality. About 1/3 of people will have the CalOR mutation. A small percentage will have MPL mutation, but there are a group of patients who don't seem to carry any of the mutations that have been identified so far. Now we know with other more sensitive tests that sometimes they can have other mutations, but that we still don't have an absolute driver mutation. And in myelofibrosis, there is a bit more of the CalOR mutation and a little bit less of the JAK2 mutation. Next slide. So as you all know, myeloproliferative disorders are complex, multifaceted diseases. So people come to us in lots of different ways. Sometimes they'll come with symptoms. So the pins and needles in their fingers or burning in their fingers, paresthesia, headaches. Sometimes people are diagnosed after they've had a blood clot. Sometimes patients have weight loss or symptoms like pruritus, and sometimes patients have splenomegaly. And then ultimately, as we follow the patients, sometimes patients develop longer term complications with patients with ET or PV changing to myelofibrosis. Patients convert to AML, which is a relatively rare complication, and there is an increased risk of secondary cancers, in particular skin cancers. Next slide. One of the things, again, I don't need to tell you about is that lots of people have symptoms related to their disorders. And this has been very well classified in using the MPN symptom assessment form. And these are all on a scale of 0 to 10. So fatigue is a very common symptom in all of the disorders. It's highest in myelofibrosis, but it's present in polycythemia and myelofibrosis and essential thrombocytosis. And this isn't just related to people's blood counts. So some people's blood counts can be relatively well controlled and they still have fatigue. Night sweats is a symptom that people can present. Itching in particular can be more of a problem in polycythemia vera. Weight loss more in myelofibrosis, and a smaller percentage of people can have fever. Next slide. So in terms of when we're treating patients, what are our goals of treatment? Obviously, cure is our ultimate goal, but we don't have treatments that can do that at the moment other than stem cell transplantation, and that's not really necessary for a lot of patients. But we want to prevent thrombosis and bleeding. We clearly want to extend survival. We want to control people's symptoms. We want to reduce the risk of transformation to AML and myelofibrosis, and as I say, cure. And unfortunately, as we're less able to do these things as we get further down with our current treatments. So really, at the moment, our main treatments are involved in this first part of the thing, but these are obviously our ultimate goals. Next slide. So in terms of thinking about how we treat people, you know, and we have risk factors both in essential thrombocytosis and in polycythemia vera. Age is a very strong risk factor because as we all get older, our risk of blood clots get higher, and that's certainly true in patients with myeloproliferative neoplasms. Anybody who's had a previous blood clot is at risk of further blood clots, so that's a strong indicator for treatment. And people who have very high platelet counts. And generally, in this patient group, our main goal is to lower the platelet count and have people on aspirin. And to lower the platelet count, the main treatments are either hydroxycarbamide or Hydrea and interferon. In lower risk patients, these are people who are less than 40, who don't have a history of a previous blood clot, and often we will treat those people with aspirin alone, unless they're having other specific issues. Next slide. In polycythemia, the risk factors are quite similar. Age and a history of previous blood clot make people into at the higher risk. We know people who have a higher white cell count seem to be at higher risk of blood clots and progression. So that's sometimes a little bit of a warning sign. And we also look at other general cardiovascular risk factors. So like whether somebody's smoking, whether they've high blood pressure, diabetes, high cholesterol levels, and obesity. And they're all risk factors for blood clots. So they would also be something that we would consider when we're deciding whether somebody or how to treat somebody. Next slide. So some of the kind of very basic things that we want to do are to look at putting everybody on aspirin. And this is quite an old trial now from 2004, which looks at the survival of people from, they're free from having either arterial or venous blood clots, so like a stroke or a clot in their legs. And the people who were on aspirin had a lower risk of, or had a higher percentage of them were free from thrombosis than the people who were on placebo. So aspirin is a cornerstone of our treatment. Next slide. And then for those of you who have polycythemia vera, you'll know that our goal is to keep your hematocrit less than 0.45. And again, this is a study from 2013, which looked at the risk of cardiovascular, so heart attacks or other major blood clots. And again, the risk was much lower in people whose hematocrit was less than 0.45 as compared to people whose hematocrit was 0.45 to 0.49. So that's not a huge difference in the hematocrit, but it does make a very big difference in the risk of blood clots. So that's quite an important goal for us. Next slide. So how do we maintain that for people who have polycythemia vera? So again, for low risk patients, venesection alone particularly in people who are less than 60 and no thrombosis. And then for the higher risk patients, again, venesection and either hydrea and interferon, usually the pegylated interferon, which is the one that we use once a week. I know there's been questions on the chat already this morning, and some of the questions that people have pre-submitted. At present, there is no data to say that interferon is better than hydroxycarbamide, and there are 2 randomized trials of hydrea versus interferon ongoing, which hopefully will answer that question. And because people live with these disorders for many, many years, it takes a very long time when we're following patients with these disorders to finally answer those questions. About 20% of people who start interferon end up coming off of it due to side effects. And often some people find that it worsens their fatigue. But for people who tolerate it, it can be a great form of treatment. Next slide. So this is actually quite an interesting paper that Claire Harrison and a number of other MPN specialists published fairly recently. And it looks at the priorities for treatment and perceptions of physicians and patients. So sometimes our goals are not always that well aligned. So in ET, often the doctors, their main goal is to prevent vascular conditions, whereas often patients are more worried about having their blood counts looking perfect. Obviously, they want to slow or delay the condition, and they're less concerned about vascular events. And throughout all of the disorders, you can see that actually our goals are not that well aligned. And that's, I think, something that these forums can be very helpful in terms of explaining where we're coming from, and for us to hear where you're coming from, so that we actually align our goals more carefully. Okay, next slide. So I suppose, as Nana has said, COVID has disrupted all of our lives over the last 18 months. And one of the big questions has been, are people with myeloproliferative disorders at more risk of COVID? And I suppose it's worth taking a step back and looking at that. What is the risk of people with myeloproliferative disorders and infections generally? And there have been 2 very interesting studies which were published prior to COVID. One earlier this year, a study that had taken a number of years to do it from Swedish data, and another one looking at myelofibrosis. And in the Swedish study of over 8,000 patients with myeloproliferative disorders, it showed that the patients were at increased risk of bacterial and viral infections as compared to healthy controls. And they were people who were mainly on hydroxycarbamide and interferon, or even patients who were not on treatment at all. They were more vulnerable to infections. This data was taken before the introduction of ruxolitinib. So people with myeloproliferative disorders are at more risk of infections, irrespective of the treatment. And then the second study looked at over 1,000 patients who have myelofibrosis and ruxolitinib, and showed that they were also at increased risk of infection. So people with myeloproliferative disorders are increased risk of lots of infections, not only COVID. But next slide. But obviously, when COVID came along, we were quite concerned in terms of trying to understand whether people with myeloproliferative disorders were at increased risk. So there have been 3 studies which have looked at that. The first is basically an Italian study, but there were some French and Spanish and Polish and UK patients on that study. And they looked at, this was in the first wave of the infection and prior to vaccination. And in this study, they reported the mortality of MPN patients who got COVID was higher than in the general population. Age was a significant factor. Male sex, diagnosis of myelofibrosis, and admission to ICU were all associated with worse outcomes. And in people who were on ruxolitinib, stopping the ruxolitinib also seemed to be associated with a worse outcome. There was no association with increased risk with polycythemia or ET. Now, we do need to take or interpret this study with a little bit of caution, because it was retrospective. So it was obviously we had to go back, or the authors had to go back and look at their patients. And obviously there were probably people who had myeloproliferative disorders who never told their doctors that they had disorders. So probably this captured the sickest patients rather than the entire population. There was a second study from the UK, which looked at 77 patients. And in that study, they didn't see any difference in outcome in MPN patients compared to patients who didn't have the disorder. So we're not really sure how much extra risk there is of patients who have myeloproliferative disorders. Okay, next slide. So the other question is, how do patients respond to the vaccination? And we still have relatively limited data on that. There are 3 small studies, and only one of the 3 studies looks at people who have had 2 doses of the vaccine. We do know that patients with myeloproliferative disorders respond to the vaccine, but there is a suggestion that patients who have myelofibrosis respond less well than people who have ET or PV. It's unclear at the moment whether that's due to the disease or whether it's due to the treatments that people are on. And obviously the question of booster doses is a very hot topic at the moment. And the kind of policies is varying really between countries. In Ireland, they haven't recommended booster doses for this patient population yet, but I anticipate that they probably will over the next couple of weeks. So I'm actually going to leave it there, and then we can come back and address some of these questions, either in the questions and answer sessions or in some of the breakout sessions. Thank you very much.
Eibhlin, thank you very, very much for such an informative talk. It's always good to catch up with the latest information, and I'm sure a lot of people will have found that incredibly useful. Thank you. I'm now going to welcome Natasha Leby. I can see you there, Natasha. And Natasha is a patient who is very kindly going to talk about her journey with PV. Come, Natasha.
Hello, everyone, and thank you for having me here today. So it was 11 years ago, it wasn't long after my father died, that I started experiencing some discomfort in my joints, especially in my fingers. I was unable to open jars or bottles, and I was very fatigued and without energy. At the time, I put it all down to stress and travel around my father's death. But it was when I went to donate blood in his memory a few weeks later that they refused my donation due to a high hemoglobin count, and they insisted that I see my GP, who on examination of my blood tests referred me to St. James's Hematology. And there I was initially assessed by a young registrar who looked at my record and noted that I was of Ashkenazi Jewish descent. And this is a few years before Dublin became as cosmopolitan as it is now, really. And this guy became like completely animated and said, Ashkenazi Jews are hematologically fascinating. Needless to say, I informed my extended Ashkenazi Jewish family in South Africa about this fact, and they were delighted to hear it. But it feels a little blurry, the time that I was waiting for the JAK test results, and I understood very little about what was going on. Tried to stop my head from wandering, especially around why I was in the hematology oncology day clinic. I also noticed at the time that people would remark on how I looked, asking all the time if I got the sun. My nose and cheeks were very red, settled now into this kind of permanent, less attractive purpley red nose, which I don't take much notice of now until I catch a glimpse of myself in a photo mirror. So yeah, and it's all a blur about what was said when I received my diagnosis. So needless to say, I turned to Google, not a good thing to do. And there wasn't much information available then. And in my non-medical, uncritical research, I found 2 once-off mentions of commonalities to my experience. Exposure to benzene, and again, the Ashkenazi Jewish piece, both of which were, yeah, in my experience. I used benzene for a protracted period during art college for printmaking. We didn't use health and safety precautions then. Anyway, I developed my own narrative around the cause of this disease. The narrative now has no basis whatsoever in truth or proof, and I never asked about it from my doctors. I wish at the time I would have come across the MPN Voice, as I know the value of peer shared experience. So I was a single parent of young children at the time, away from my family in South Africa. I didn't discuss how I was feeling much around my children, only to tell them I was off to give blood because I had too much, and that made me a little tired. I kind of seemed to everyone pretty blasé about the condition, but I really was fortunate to have a good friend with whom I could turn over any concerns and neuroses I might have around my mortality and my fears. And she held a safe space for me to do that, and this gave me real perspective on the situation. So my treatment plan till now has been venesection and low-dose aspirin. I've briefly discussed other options with my consultant, but I am clear that my personal preference is to avoid medication for as long as possible. The venesection isn't without its issues. It seems to me that when I arrive at the clinic, the nurses run from me. I'm notorious to deal with, as I only have one vein which is vaguely accessible. It's difficult to coax into action and oftentimes gives up halfway. And whenever I offer the other arm, it seems to hit, there's a nerve that gets hit and it's way too painful to continue. On 2 occasions, I've had to have the withdrawal taken using a smaller needle and countless blood testing vials. I often wonder what will happen when that one well-behaved, albeit shy vein gives up completely. It's such a shame every time I see this blood being discarded. It was explained to me a while back why. Now, I don't fully understand it, and my interpretation comes via the science fiction genre. But seemingly, if our blood is donated, there's a tiny chance that some dodgy cells can clone in some poor unsuspecting body, and they too might develop an MPN. Don't accept this interpretation. Ask a much more reliable source like your consultant or MPN Voice. Whatever the reason, my blood collection just goes straight into the bin. And in spite of me asking the nurses and my consultants several times to let me bring it back home, they haven't allowed me to test my theory that it will help me fertilize my plants. How else does this impact on my day-to-day life? Well, the fatigue. Sometimes I feel wiped out, as if I could go to sleep standing, or when I drive, I need to stop after a relatively short distance. And I can't binge watch Netflix because I fall asleep in front of the first episode. Now, I'm not absolutely sure if the source of this fatigue, it could be PV or single parenting or menopause or just the aging process. But many times after venesection, I feel like I have renewed energy. That's another one of my Natasha narratives, but I will go with that. Then for me, there's brain fog. Again, the cause of that is many possibilities, aging, menopause, whatever. I grasp for words. I have to write down stuff or else I forget. On the plus side, I make an excellent confidant because your secrets are always safe with me, because no sooner you share them with me, they're quickly forgotten. And air travel, remember those days. I have to wear those kind of extraordinarily uncomfortable full-length travel stockings. Also, my travel insurance requires an extra policy to cover PV. And because I fortunately haven't had a DVT, the cover isn't too high, an extra 30 or so euros a year. And I pay that yearly whether I travel or not for the peace of mind. Then there's trying to explain to people, friends and colleagues, why you need time off or why you have venesection. And my constant answer is, no, it's not hemochromatosis. And even the GP has seemingly very little knowledge of this condition. And the positives, there are. And first of all, the early vaccination list, that was great. The security of being consistently checked and minded by the staff at St. James's. I was never one for GP visits, but it's very reassuring to be monitored despite the waiting time at clinics. It's a beautiful thing, that sense of being minded and monitored. I was very moved a few years ago when I asked my consultant, Dr. Conneally, why she chose hematology as a speciality. And she replied that she prefers dealing with chronic disease, that it allows her to build a longer-term picture and plan for her patient. I read that as quietly heroic and full of care and commitment. The regular visits to James's also in a strange way present me with another community of staff and fellow patients united by some shared experience. It has also given me time to monitor and reflect on my health. And from an 11-year overview, I've convinced myself that there are more extended periods between vivisection and treatment when I exercise regularly, when I mind my well-being, when I eat well, stay hydrated, and take care. This again is a narrative I've written for myself and may have no basis in statistics or proof, but hey, it can do no harm, only good. I also wish that I was disciplined enough to heed my narrative more often. Also, out of interest, I've noticed that when I was menstruating heavily, the time between treatment would increase. That unfortunately no longer applies to me. On the positive as well, if one must have a condition, PV is by no means the worst. And I'm very conscious and respectful of all your individual experiences when I say this, but for me it is manageable. I've found a way to live fully with it, and there's always hope for new breakthroughs and options going forward. I suppose when something irregular is going on with your body, it invites you to reassess how you live your life. For me, understanding and accepting that I have reduced energy and increased fatigue invited me to choose to live my life at a different pace. I've been fortunate enough to choose work with reduced hours and with a lot less stress. The pay is very basic, but it just about allows me to meet my outgoings. I live simply and abundantly with more time to spend with friends and family. So with all this new zen and acceptance and wisdom, 2020 was going to be my year. My daughters had plans to leave home. I would have space and time for myself. I was going to take time out of work, maybe rent out my house and supplement my income that way to have my Shirley Valentine moment on a Greek island. But then COVID had different ideas. Also, during this time, the universe presented me with an opportunity to foster a vulnerable young child in an emergency situation. She arrived at my doorstep in November last year and has been with me since. During this time, I was assessed by TUSLA for my long-term suitability. The fostering assessment team concluded after a vigorous assessment that I was deemed suitable to foster long-term, sound mind and all, depending on my medical reports. It all came down to the consultant's report, and I was ready for the no. And indeed, part of me was hoping for a way out of this huge commitment. But Dr. Conneally, without a second thought, deemed me fit to foster, which is a good thing because this child has robbed my heart and there really is no turning back. And so here I am, single parenting a young child again for the foreseeable future for at least 10 more years. I'm menopausal, I'm sometimes grumpy, I'm red-nosed, I'm in my 50s with an MPN. And still my consultant confirmed on my medical report that she thought I was fit enough to do this huge job for the long term. And it is this confirmation which has provided me with the broadest perspective of the impact of the disease on my life. And thank you all for listening, and thank you to the hosts and the other participants for sharing your stories and your invaluable knowledge. Thank you.
Natasha, thank you so much. When I first spoke to you, you said, I don't know why you're asking me to do that. I haven't got anything to say. And you've given us so much insight into your journey of PV. Thank you. And I'm delighted that you agreed to do a patient talk.
Thank you. Thank you, everybody.
Okay. Now, our next speaker, I'm just waiting for the thing to come up. Our next speaker is Dr. Clodagh Keohane, who is going to talk about clinical trials and MPNs. Welcome, Clodagh, and thank you for all your support to MPN Voice.
Good morning. I hope everybody can hear me. Getting a thumbs up. Danny, are we okay?
Yes, you're great.
Yeah, great. Okay, just checking. Thank you, Nona. Clodagh Keohane is my name. I'm a consultant haematologist in Cork in the Mercy University Hospital. I have a special interest in myeloproliferative neoplasms, and I'm absolutely delighted to be talking today. I did most of my training in Ireland and my specialist MPN training in the UK at Guy's and St Thomas's, and mostly in clinical trials in myeloproliferative neoplasms. I've been back in Ireland now for nearly 8 years, and I've set up a specialist MPN clinic in Cork, and I've worked very closely with Eibhlin Conneally in Dublin in trying to set up more clinical trials in MPN in Ireland. Next slide, please. So for this short talk, what I wanted to do was to give a very brief introduction to what clinical trials or clinical studies might be, and then to take you through some of the current things that are happening with MPN and research and clinical trials in Ireland at the moment. And then just talk very briefly about future directions. Next. So what is a clinical study? I'm conscious that some people might know a lot about this and some people might not know anything at all. So really, when we talk about a clinical study or a clinical trial, we have a question that we want answered. Sometimes that question is one drug or medication better than another? And sometimes it's more of an academic question, like what has caused a disease. When we talk about a clinical trial with a medication, you'll often hear the terms a control group, and that's when patients might be entered into a study but don't get the drug that we're studying, maybe get a drug that's well known to us already. And randomization is a term you might hear as well. That's where a patient is entered into a study and a computer program will randomly assign the patient to either the drug of interest or to the other therapies available. And you might also hear the term blinded, and that's where both the patient and the study doctors and nurses are unaware of which medication the patient is receiving. And all of these have different purposes and give us slightly different information. Next slide, please. So what are the benefits of a clinical study or a clinical trial? And really, from the patient perspective, the huge potential benefit is early access to new and novel treatments. So while MPNs are a fascinating subject, and there's been huge amounts of research and development in the last few years, new drugs are coming online all the time. But it does take quite a long period of time for a drug to become in the general use. There's a lot of regulations that have to be met and approvals that have to be met. So if a drug shows very early promise, a clinical trial is really the way of getting access to that before it's generally available. Clinical trials can often give a patient a more active role in your own healthcare. You can get more frequent checkups. It's quite intensive in terms of monitoring. And there's also the altruistic benefit of the potential to help others get better treatment in the future. Next slide. But of course, as with everything in life, there's always potential risks. So any new medication can cause side effects, some predicted, some unpredicted. There's also the chance that the medication may not actually work. There's the chance that a patient might be enrolled in a control group and not an active group, and that can obviously have huge disappointment. And then there's the inconvenience of attending regular visits far and above what would be the standard of care for somebody outside the setting of a clinical trial. And remember, if you're, for example, if you're from West Kerry and you have to come up to a clinical trial in Cork, you know, 2 or 3 times a week, that is a huge commitment. Next slide. Clinical trials have a huge amount of rules and regulations around them, and that's all because of patient safety. We do our absolute utmost to make sure that things are as safe as possible. And clinical trials are governed by a huge amount of regulations. So every trial has to have ethical approval. The people who carry out the trials have to be specifically trained in clinical trial. We have external reviews to make sure that everything is remaining on track. And there are extremely strict study protocols for every single clinical trial or research study. So that means that there are strict, what are called eligibility criteria, you know, things that make you suitable for the trial and things that make you unsuitable for the trial. And this cartoon, I think, reflects some of the difficulties and challenges with clinical trial. Next slide, please. From an Irish perspective and from a general perspective, there are challenges to setting up clinical trials. Funding can often be a huge stumbling block. So some studies are run by pharmaceutical industries, and a lot of those studies will be the drug studies. They often come with a lot of funding and can be reasonably straightforward to run. But some academic studies, like, for example, the MOSAICC study that I'll talk about later and that Nona mentioned, are not particularly interested in a drug, but ask a bigger question, like, why does somebody develop an MPN? These studies often don't come with any funding, and clinical studies are extremely expensive to run. And so there's a challenge there in terms of trying to get funding to allow these studies open and be accessed by our patients. Sometimes we suffer a little bit in Ireland because we are a smaller country. And if you're looking at a rare problem, then you might not have a lot of patients in that country, and then it can be difficult to justify setting up a study for a small patient cohort. And some of the geographical challenges I've already mentioned. Next slide, please. So I'd like to take you through now some of the research topics and studies that are ongoing in Ireland at the moment. Next slide. So this is just a little diagram of what we have open and what are opening. So we have 2 large pharmaceutical studies open at the moment, the Freedom 2 study and the luspatercept study. We have the MOSAICC study opening imminently. Roger in the next talk is going to talk about a thrombosis research study that's opening. And we also have smaller, more hospital-based clinical audits relating to MPN, and they're more about making sure that we are keeping our standards up to international standards and providing the best care. Next slide. So I thought I'd take you through the luspatercept study now. So this is a clinical trial currently open in St. James's Hospital in Dublin and opening very, very shortly in Cork, with a potential for a further site in Dublin in the near future. This study is for patients with myelofibrosis who are also anemic and have the need for regular blood transfusion. And these patients will usually be on the JAK inhibitor Jakavi or ruxolitinib in addition to their transfusion. And luspatercept is a drug that has shown some promise in terms of reducing the amount of blood patients might need. So this study is, as I said, open and actively recruiting. If you think you might be interested or eligible, please contact your consultant, who will all know either myself or Evelyn, and be more than happy to give some advice and further information. Next slide, please. The next study is called the Freedom 2 study, and this is currently open in 3 sites in Ireland. It's open in St James's Hospital in Dublin, in the Mater Hospital in Dublin, and in Cork. And again, it's for patients with myelofibrosis who are not doing very well on ruxolitinib. So this study is aimed at people who are kind of losing their response, who may be developing a big spleen again, or may have developed other problems. And it is interested really in asking the question, could you now respond to a different JAK inhibitor called fedratinib, which is not available outside the setting of a clinical trial in Ireland. This study has something called a crossover, which means that if you are randomly assigned to the best available therapy group, you have the potential to, after 6 months on the study, receive the fedratinib drug as well. So this can be attractive for patients because if you don't get it at the start, there's a good possibility that you get it after 6 months. Next slide. The goals of this study really are to see whether your spleen will reduce again, and whether your symptoms, your TSS, your total symptom score, will reduce again. Obviously, we're also interested in any potential side effects and on overall survival. Next slide. So the next study, and a study extremely close to my heart, is the MOSAICC study. So this is a case-controlled study for all MPNs. So it's anybody with a diagnosis of ET, PV, or myelofibrosis within the last 2 years. And this is an academic study, so not a pharmaceutical-based study. And the goal of this study is to try and determine were there any environmental, any lifestyle, or any medical causes that could have potentially influenced the development of a myeloproliferative neoplasm. This is a UK and Ireland-based study. Next slide, please. As you can imagine, it is a bit like trying to find a needle in a haystack as to what causes an MPN. And so this is a very important study, particularly from a patient perspective, to try and get some answers. Next slide. Mary Frances McMullen from Belfast and Leslie Anderson in Aberdeen have looked at a pilot study. So that's a kind of a baby study in a small amount of patients, trying to get any hints as to potential causes. And there were some interesting findings in that people who were JAK2 positive seemed to be twice as likely to have been smokers, which potentially may have played a part. And for patients with ET only, before diagnosis, ET patients were probably twice as likely to have had obesity, which may potentially have played a part. There's also some hints that maybe early CT scanning might have had an implication, but that's a bit trickier to pull out because some patients might have a CT before they're diagnosed for another reason and may not be contributing. So there are some early signs here that were of interest, and these were published, next slide, recently, and form the basis of our further investigations now. Next slide. So this study is going to be open to 650 patients is what we're hoping to recruit, and 650 controls. As I said, It can be any MPN diagnosed within the last 24 months. And the reason it has to be within 24 months is that if you've had an MPN for a longer period of time, you might have changed your lifestyle or made some modifications that may, what we call, confound the study, and we may not be able to pick out the factors as clearly then. So we're looking for new patients. Next slide. So we're looking at lifestyle factors, medical factors, occupation, genetic causes, and then potential toxins in everyday life that we know can sometimes cause cancer. We're also very interested in quality of life, because as you can see from the picture here on the screen, the red line is patients with myeloproliferative neoplasms and the blue line is controls. And we can see that patients with MPN have a much higher symptom burden than people with controls, people who don't have an MPN. Next slide, please. The MPN Voice have been hugely supportive of this study and undertook a very interesting survey that some of you may have contributed to in 2019, wondering from a patient perspective what factors you thought might be implicated and that you would like us to look at. And that has been taken on board, and these have been included to the best of our ability in the study. Next slide. So this study is a very simple study where we just take 3 blood samples, and we also take a swab of saliva from the mouth and a toenail cutting. And we do this from a patient and from the control, which the patient usually brings themselves. So that's a non-blood relative or friend who's of the same gender and about the same age. So certainly in Cork, we're looking at seeing the patients and controls at the same time for ease, and taking all these samples on site. Later on then, there's a telephone consult looking at lifestyle factors and a questionnaire. Next slide. So in the UK, there's been a huge drive for funding, and most sites are, if not up and running, will be up and running very, very shortly. Next slide. And next slide. In Ireland, we have done a huge kind of fundraising drives to try and get the MOSAICC study open. It is about to be opened in Cork, and hopefully with additional funding, we'll be opening in St. James's in Dublin and in Limerick as well. Next slide. And then I'm conscious of time, so in terms of novel therapies, just to let everybody know that there are lots and lots of medications coming down the line. All of these are in clinical trial at the moment. Some are for myelofibrosis because patients generally have the greater need, but some of them are also for PV and ET. And just to say from I suppose a clinical trial and research perspective, that MPN is a very exciting field with huge promise for the future. Last slide. And this is a lovely picture of the Mercy Hospital in Cork. Sadly, this was taken before COVID, and we now have lots of horrible prefabs that I hope won't stay for very long. Thank you.
Clodagh, thank you so much for your talk. And as you know, we at MPN Voice, it's our major fundraising activity for MOSAICC. And we are just so thrilled that there are going to be sites in Ireland. And it brings the connection with you, having done your training, some of your training at Guy's and St. Thomas's, very much in touch with all of us. Thank you. Our next speaker is Dr. Roger Preston. My co-chair, John Matthias, and I had a introduction to him from Eibhlin a couple of weeks ago. And I'm delighted to say that we're going to be collaborating, MPN Voice are going to be collaborating in a new study, which he is now going to talk to us about. Welcome, Roger.
Hi, Nona. Thank you very much for the introduction. I'm going to share my screen now, if I can.
That's fine.
Can everybody see that okay? And can you hear me okay?
Yep, if you just want to go into presentation mode so we get it full screen, that'd be great. Thanks, Roger.
Is that okay? Okay.
Perfect.
Well, first of all, thank you very much for the invitation to speak today at this MPN Voice Forum. I really appreciate the opportunity to talk about the new study which we hope to initiate in the coming months. And also thanks to Clodagh, who spoke before me. It's a fantastic job of explaining clinical research. And this is the kind of research that we'd like to perform here. And this is an academic study. So that's a study which is performed by researchers working in hospitals and universities to try and better understand how MPNs work. And so just some background about me. My name's Roger Preston. I'm a researcher at the School of Pharmacy and Biomolecular Sciences in the Royal College of Surgeons in Ireland, based in Dublin. And I run a research laboratory that studies how blood clotting works and how it happens, and particularly how different types of inflammation can contribute to an individual's risk of having a blood clot. And so my expertise is in the setting of blood clotting and in thrombosis. And so the project I'm going to talk about today is really about better trying to understand how different MPNs can contribute to an increased risk of thrombosis. And the study which we are hoping to plan to try and investigate this more thoroughly is called the Clotting and Inflammation in MPN Blood, or the CLIMB study. So what I'm going to talk about today is just really give a brief overview of the study as we hope to perform it, and really to talk about the people who are involved in it, what we hope to try and understand from the study, discuss how we've put together this particular team so that it has I think a really great combination of scientific researchers from different specialities. We have clinical collaborators too, some of whom you'll know. And also an involvement from MPN Voice, which we feel is a really important aspect of the study. And of course, patients too, patients who have MPNs, who we hope to be able to recruit to this study. And I also want to give you an overview of where it's at right now and how we hope to progress it in the future. So this is a study which really came from discussions between myself and Dr Conneally at St James's Hospital in Dublin, who many of you know, and we're really aware of the differences in understanding of why thrombosis happens in individuals with MPNs, and to why some individuals have more chance of having a thrombotic event than others. And the biology underlying that is actually really poorly understood. And as a consequence of that, the treatments for it are less specific. And we really want to try and understand the biology of how this happens much better, because that will enable better treatments to arise from that. And so myself and Dr Conneally started this idea of looking at blood clotting in patients with MPNs, and particular cells from the blood, which we feel might be important contributors to that risk of thrombosis. So all research projects start with a research question, and usually it starts with a question which you want to try and interrogate or try and understand. And to me, as someone with a lifelong kind of interest in understanding thrombosis, what I'm really interested in trying to understand is why individuals with MPNs are more likely to experience, that should actually say a blood clot rather than a blood cell. But to really understand why that happens, because there is a significantly increased risk, as you're all aware, and really the understanding of what mediates that is actually relatively poorly understood. And so our question really relates to whether particular white blood cells, which are elevated in MPN patients, may change qualitatively. That means they may have different properties to people who don't have MPNs, which means they're more likely to drive the formation of a blood clot. And so this is something that is actually very poorly understood, and something which we feel are a combination of expertises in MPN field and thrombosis may be able to provide a unique perspective. And the reason why we think this is really important is because if we can identify a role for a particular cell type which we think may contribute to this thrombotic risk, well, this gives us an opportunity to study these cells in MPN patients much earlier to see whether we see qualitative changes which might lead to thrombosis. And perhaps most importantly, it provides us with the opportunity to target new drugs which may be able to reduce thrombotic risk in MPN patients, specifically targeting what we think might be the cause of that. So how do we want to try and do that? So we have a plan, and part of this involves studying blood, particularly from MPN patients, who we hope to be able to recruit to the study whenever they attend St James's Hospital for clinic visits. And the idea is that we'll hopefully be able to isolate blood and a particular cell type, which we think may contribute to this risk of thrombosis, called monocytes, and take those cells and assess whether those cells are more likely to start blood clotting in plasma compared to monocytes from people who don't have MPNs, which is a control group, which is what Clodagh mentioned in the last talk. So the idea is to compare the ability of these two cells, which we can isolate using techniques which we've established in the lab, to see whether they're more likely to cause clotting than the control group. And one of the things we want to test really for the first time is whether we can use particular types of anti-inflammatory drugs to change the properties of those cells such that they become less likely to trigger blood clotting. And we have some preliminary data which suggests that we can start to test that using some of the techniques and experiments which we've established in the laboratory. And so we've developed it. So what we really want to be able to do is to be able to identify those MPN patients who may have increased risk of thrombosis earlier on. And we've designed this test to be able to look at how a white blood cell can contribute to blood clotting. And so normally whenever blood is tested for clotting ability, what we're really doing is looking at just the blood, usually minus any of the cells in the blood. But what this test enables us to do is we can take blood from a patient and we can combine it with white blood cells, which we've isolated, and then mix it together. And we can actually measure a clot then forming in real time using some complex machines which we have in our laboratory, which allows us to see clots forming in real time. And we can tell then whether those white blood cells we've isolated are actually more prone to help clotting than those from perhaps a control group. So what we'd like to do is really use this test as a way of determining whether they might be useful in identifying patient white blood cells which might be more prone to clotting. And so that's really kind of the questions we hope to try and answer. But it's really important to point out, this isn't just an entirely scientific study done by people in the lab. This is a project which involves lots of different people with different expertises, and that's a really important feature of scientific studies, to get lots of different opinions and perspectives which feed into making the research better. And so for that reason, we have a project steering group, and that steering group includes multiple people from different backgrounds, including scientists such as myself and other scientific collaborators who are involved in the study, and Dr Conneally, again, who's providing expert clinical guidance in terms of how we perform the study. And what's important as well is we also have patient representatives who are also part of the project steering group. As you heard, Nona and Jonathan are going to join the project steering group to ensure we have a patient voice who can contribute valuable perspective to the study throughout, evaluate the research as we do it, and make sure we're addressing questions which are actually relevant to MPN patients. So I just want to talk about the goals of the study. So really what we want to do is to better understand what individuals with MPNs have an increased risk of thrombosis. To our mind, this is poorly understood. And we want to really understand whether we can use new tests that might well measure white blood cell clotting activity. And we could use that test then to identify those who are most at risk. And ultimately, what we really like to do is to use all this information together. And if we're able to identify particular cells which are important in that thrombosis, risk of thrombosis, then we can design better targeted treatments to reduce the risk of thrombosis in those individuals who are most at risk. And we have some candidates which we're interested in testing, and we hope to be able to explore more in this project. So the current state of the study is, as Clodagh mentioned, one of the key aspects of research throughout the world is ensuring we have funding to do it. And so we hope to be able to initiate it, at least in a small scale, beginning in the next few months. And we have applied for significant funding from the Health Research Board here in Ireland. And we also will be looking for funding from other avenues as well, both in Ireland and internationally. And we have done preliminary work to support the initiation of the study, and we're going to be applying for ethical approval to start the project at St James's Hospital, and hopefully later this year, and hopefully the start of next year. And so what I would say is, if you're patients in St James's, then to be aware of the study, and we may be hopefully speaking to you soon. And so just finally, I want to acknowledge Dr. Conneally for fantastic support and expertise in contributing to design and development of this project. And really importantly, to thank Jonathan and Nona for their support and guidance in setting up the study and its design, and also for giving me the opportunity to speak to everybody here today. So thanks very much.
Thank you, Roger. And once again, John and I and the whole of the MPN Voice team are really excited at the prospect of collaborating with you. And it's an amazing study that's much needed. Thank you.
So, thank you.
Okay. Our next speaker, is Mary Kelly, who is a nurse from the Midland Regional Hospital in Tullamore. And Mary is very kindly going to give us an update and the results of the patient and caregiver survey, which I remember when we were in Cork a couple of years ago was where it was first instigated. Mary, thank you so much for updating us on this.
Thank you. Can everyone hear me okay?
Yes, we can.
Perfect. So I'd like to present today the findings from the questionnaire completed at the Patient and Family Day in Cork on behalf of the working group. I would like to acknowledge that the questionnaires were reviewed by Dr Keohane and endorsed by MPN Voice. Next slide, please. So these are my disclaimers. We were a collaborative working group of nurses, four nurses in total, 2 advanced nurse practitioners and 2 clinical nurse specialists. We did receive funding from Novartis Ireland, and this was limited to the steering group setting up those meetings and the funding for our publication later. Novartis Ireland were not involved in the dissemination of the questionnaire or any of the data collection or analysis, and my slides today have been prepared by myself. So next slide. So as we know, myeloproliferative neoplasms are a group of clonal cell disorders, and this results from the abnormal production of the stem cells. What we see is an increased production of white cells, red cells, or platelets in one or more lines, and this differentiates then to which subtype a patient may develop. MPNs are rare, they mainly affect adults. And the latest data I had was on 2015 from the National Cancer Register, which identified 153 patients in Ireland with this condition, newly diagnosed. Next slide, please. So despite treatment advances, most MPNs treatment is non-curative. It is associated with an increased disease burden, reduced quality of life, and shortened survival. There have been 2 landmark studies looking at the experience of patients living with MPN. These revealed that the symptom burden was substantial. It had a negative impact on quality of life and daily living and productivity of patients, as well as an impact on patient families. To date, to our knowledge, no previous study had been performed to examine patients in Ireland's experience of living with an MPN, and also the caregiver's experience of caring for a patient with MPN. So we set up a working group of clinical nurse specialists and advanced nurse practitioners with an interest and a caseload of MPN patients, and we formed a working group supported by Novartis. We adapted the previous studies, the MPN global study, and we reduced the number of questions so that it was adaptable to perform at a one-day event. So we had 2 separate questionnaires, one for patients with 29 questions exploring their experience of living with an MPN. And then we had a caregivers survey, which had 19 questions. It's important to say that both questionnaires were not linked. Sorry, I meant to say next slide. So I've covered this, so we'll go to the next slide. Unlike the UK and other countries, support organisations for MPN patients in Ireland do not exist. There's also no national database. Therefore, the convenience sample of those attending the MPN Voice Patient and Family Day in Cork was our target population. 2 members of the working group, myself and Ger Walpole, attended this conference and presented the aims and objectives, addressed confidentiality and informed consent. We then distributed the hard copy surveys to the patients and caregivers and collected these at the end of the day. It's important to highlight that the responses were confidential and protected by data consolidation. We know that the physical and psychological impact on caregiving is well established. However, there was limited data on the burden of caregivers of MPN, and this is why we chose to include caregivers. We defined a caregiver as a person who assisted the patient with activities of daily living. As I've mentioned, myself and Ger collected the surveys at the end of the day and analysed them, and later presented them to the working group. Next slide, please. So 95 surveys were completed on the day, 51 from patients and 44 from caregivers. 67% of the respondents were females and 55% were males. Of the patient group, 68% were living with an MPN for 2 years, and 47% were living with it for over 4 years. Patients described, 70% of patients described as their health being in either good or excellent health. However, 29% described their health as poor. In the caregiver group, 56% were providing care for over 2 years, and 36% were providing care for over 4 years. Next slide, please. So we analysed the data looking at diagnosis and then at questionnaire completion. So 4% of patients had no symptoms either at diagnosis or at time of completion of survey. However, the majority of patients, 70%, had fatigue. Pruritus was the next top symptom at 37% and dizziness at 35% at diagnosis. There was a change from time of diagnosis to completion, the most significant being that fatigue remained the top symptom, but in fact had increased from 70% to 86%. And we know that fatigue is under-recognised and should be a target for modifiable input in the future. Bone pain was also high, and pruritus remained in the top 3 symptoms. Bone pain, fatigue, and pruritus were the 3 top symptoms patients wished to have resolved. Next slide, please. So despite the majority, 98% of patients were on treatment at the time of the survey. Only 51% reported that this had a positive impact on their daily lives. MPN impacted on their energy levels, in a great majority at 70%. Sleep was also affected at 37%, and the ability to exercise was affected by 53% of patients. As we can also see in the graph, sexual, social, and professional lives and patients' ability to care for one's family was also significantly affected. Taken together with the symptoms, this data suggests there is a need to develop strategies for proactive symptom management, incorporating self-care strategies and modifiable lifestyle changes for reducing physical and psychological symptoms of patients living with an MPN. Next slide, please. Of the caregiver group, over 60% were caring for their spouse. Parents was the next biggest group at 27%, and other forms of support included children, siblings, and other relatives. Next slide, please. Emotional support and companionship were the most needed support types. Other forms of support included transportation, financial, and homemaking. Of interest, 68% of caregivers felt they spent 1 hour a day providing care, but 9% needed 4 hours or more support. Next slide, please. We explored patients' emotion of experience at diagnosis of an MPN. And unsurprisingly, 80% of patients were fearful or distressed at time of diagnosis. 12% described themselves as depressed. At the time of completion of the survey, almost 46% of patients felt anxious or worried about their condition often or all of the time. And what was interesting also was, despite treatment levels being high, the depression levels of patients had risen from time of diagnosis from 12% to 20%. Next slide, please. The most common emotion experienced by caregivers at the time of diagnosis was worry and concern. Fear and anxiety also featured. And when asked about the future, caregivers reported being concerned. However, it was nice to see that 43% also were feeling very hopeful about the future. Next slide, please. Most patients felt that the MPN diagnosis had a minor or no impact on their emotional well-being. However, for 32%, it was having a greater significant impact. Whilst this was important to note, what was even more interesting was that there was a higher emotional burden on caregivers, with a third stating that their providing care for their patients had a great to significant impact on their emotional well-being. Next slide, please. We also were interested in the support patients had received. So following a diagnosis, the majority of patients had received support from their family. Healthcare professionals was also important. However, 10% reported having no support. What was interesting also was that 70% of patients felt at diagnosis they would have benefited greater if they'd had more education, more emotional support, and more peer support. The desired sources of support were healthcare professionals, support groups, and family. Next slide, please. Similarly, caregivers felt the need for more support. They felt that they had received, approximately half of them felt that they'd received information at diagnosis of the MPN. However, what was also interesting to note was 45% of caregivers did not feel included or taken into consideration by their medical or nursing teams. Both groups felt that more information and support were required at diagnosis. And this highlights the extent of treatment support and information throughout their diagnosis and living with their disease. Next slide, please. The majority at the end, so at survey completion, felt that they had been well informed about the disease, that they were well supported, and that their doctors understood their situation. Next slide, please. So in terms of ongoing support, 94% of patients had no local support group, 82% of caregivers had no support, and both groups requested the need for more information and support from support groups locally. And what was interesting also was caregivers felt there was a need for more public information, especially for GPs and family. Moving to the limitations of our study, this was a small study. It was descriptive in nature, so this precluded the statistical comparison of data. It was a small number, as I've mentioned, and this may introduce bias. It was a group of patients and caregivers attending the information days, and patients at this stage tend to be more engaged or perhaps have a lower symptom burden, which again may have influenced our data. The questionnaire did not categorize patients by group, and we know that symptom burden is much higher in patients with myelofibrosis compared to ET and PV, and this could also have impacted the results. Next slide, please. So in summary, this is the first Irish study exploring patient experience of living with symptom burden and the caregiver's experience of managing or helping a patient live with MPN. Treatment benefits were high, however, symptom burden remained high also. And this highlights the need for further research in this regard. It also highlighted the need for perhaps more information on the prevalence of MPN in Ireland and addressing patients' unmet needs. Next slide, please. Educational support and interventions which incorporate self-care and modifiable lifestyle factors may be effective in meeting this need and helping reduce symptom burden for patients. We also need to build on the requests of patients, including support groups. Next slide, please. So the future plans, I'm delighted to announce that the publication of our study or of our survey will be next week available in the British Journal of Nursing. Our working group is exploring the possibility of support groups around Ireland. We're also collaborating with the Irish Cancer Society and the National Cancer Control Programme in educational programs for patients. And one such programme which is now going to be available is the LACES programme, which is designed for patients who are living with chronic cancers. And this will greatly impact on educational needs of patients. And I encourage you to ask your nurses or doctors to be referred to this. This is our study was a small survey, and possible research for the future can be explored. And finally, I would like to acknowledge and thank the patients who participated in our survey and the caregivers. I would like to thank MPN Voice for the opportunity to carry out the survey on the Information Day and obviously to present it today. I'd like to thank Dermot, Paulina, Anne-Marie and Sinead from Novartis. And finally, my colleagues in the working group, Avril, Joy and Geraldine. Thank you. And apologies.
Mary, don't worry. Mary, thank you so much for all that information. It's really interesting. The caregivers who feel that they need more information and support. Normally on these forums, face-to-face, we run a specific family and caregiver support group in the breakout groups, which sadly we can't do online. But, you know, we'll be there in Galway next year, fingers crossed, and we'll have a support group running in the breakout groups for the friends and family then. But thank you so much. Thank you. We now are going into our Q&A session with the doctors. Two things I need to mention. We are well aware that we are running late. We will still have our 10-minute comfort break, but there are so many questions that have come in that we will take the comfort break and let this session run for 30 minutes and then shorten the breakout groups so that we do have to finish at 12:30. Anyway, it's now over to the clinicians here, and Dr. Conneally will chair this session and we will try and answer as many questions as possible for you.
Thank you very much, and thank you very much to everybody who's given talks this morning. On the registration site, I know some people there was an invitation for people to submit questions, and actually we've had quite a lot of questions through that, and then a couple of questions that have come in over the course of the morning. But I'm going to start off with the questions that we got online first, and then we'll come to the others. And I suppose some of the questions are we can group them, and some may have been already answered this morning. Not surprisingly, given the last year or two, there were lots of questions about COVID and the vaccine. And I suppose two of them were, I'm fully vaccinated, taking hydroxycarbamide for ET, and told I'm not immunocompromised, so what are the potential risks associated getting COVID given my condition? And then there's one from, how has COVID affected PV patients in the 50 to 60 female bracket? And I'm going to take those questions because I've had quite a good look at the data that's out there with respect to COVID. It does seem, and the data is limited in terms of the number of publications. I have to premise everything I say about that, but we do know that people who have blood cancers in general differ in their way they respond to vaccines. And there are groups of patients who have multiple myeloma and lymphomas who are on treatments that very, very significantly affect their ability to respond to vaccines. For people with myeloproliferative neoplasms, the data is much more encouraging. But as I say, particularly for people with myelofibrosis, there does seem to be a slight reduction in the response to vaccines. Based on the data that we have so far, there is less of an impact in ET and polycythemia vera, as far as we can tell. I suppose the difficulty for all of us in terms of how we go forward, given that there's quite a bit of COVID still around in the community, I think we kind of still need to be a little bit cautious. And certainly in my own kind of personal practice, I am still quite cautious. I'm not enthused about attending massive gatherings. I tend to try and meet people outdoors, and I'm careful in terms of knowing who I'm meeting and particularly making sure that people are vaccinated.
I think I'd echo your sentiments there, Eibhlin.
Yeah.
I suppose it's anecdotal, but certainly in Cork, particularly in the last 2 or 3 weeks, we've seen more COVID in our hematology patients than we did a year and a half ago. So as things open up, I still am cautioning patients to be very careful.
And then the second group of questions regarding COVID was about antibody responses and should people have antibody tests? And again, this is sort of a watch this space thing. We don't really know how to interpret the antibody responses. And there are two parts to our immune system. There's kind of the antibody responses, and then there's the kind of more memory part, or the T cell part of our immune system, which is also very important. So some people won't have very good antibody responses, but they will have developed the other part of their immune response. So antibody responses on their own are not likely to tell us the full story. So again, probably unless it's part of a research study, there's not an awful lot of value in people getting antibody testing done, because we don't really know how to interpret them. And any thoughts on that, Clodagh?
I suppose the data isn't there yet. This is all so new and so early. But I suppose our gut feeling is probably that there is some lowering of immunity after initial vaccination. And the big question now, I suppose, is boosters, and I'm sure you're probably coming to that. But I think boosters will probably be of benefit, won't they? Yeah.
There was some questions about the Octave trial in the UK. So that was a trial run through a number of centres, and it looked at a range of patients who potentially might have decreased responses to vaccines. There were some people with blood cancers within that study, but they didn't break down how many of them had myeloproliferative disorders as compared to other type of blood cancers. So it's actually very difficult to interpret data from that group. And as the best data has been from, there's some data from the Oxford group and from the group in St. Thomas's, the Guy's group. Their data was mainly after the one vaccine, and then the Italian data was after the two vaccines. So we've talked about that earlier. Booster doses or extra doses, I guess, people are kind of differentiating those slightly. I think when people are talking about booster doses, they're actually often talking about the entire population. And whereas when people are talking more specifically about extra doses, they're talking about people who may not have responded completely. There isn't yet a final answer from NPHET and NIAC for people who have conditions that may have left them to be less responsive. But I think that will come over the next couple of weeks. And I think it is likely that people who have myeloproliferative disorders will be recommended to have an extra dose. And again, how that will be administered, whether it will be administered to the hospitals or the vaccine centres, you know, that still hasn't been decided. Anything from your point of view on that, Clodagh?
No, nothing extra to add. Yeah, we're slightly in the dark on that front, I think. Yeah.
Okay. So just to move on to some of the more general questions, there was what's the best drug for PV treatment? Currently on Hydrea, and reading that Pegasus is better from a disease perspective. Clodagh, do you want to address that?
So I suppose you dealt with some of that in your talk, didn't you, Evelyn? In that, interferon is a very good drug if you can tolerate it, but we don't have the evidence to support that it is better than Hydrea as yet. I suppose in our younger patients that require what we call cytoreductive therapy, we often tend to go with interferon. But it has, a significant side effect profile that can make it sometimes a difficult drug to take. But hand on heart, we can't say that one drug is better than the other. And in the over 60 age group, hydroxycarbamide or Hydrea remains our first line therapy.
Again, there was another question about what are the long-term effects of taking interferon, say for 10, 20, 30 years or more. Is that known yet?
I suppose it isn't. It isn't known yet. We have lots of patients who've been on interferon for a long time, but probably not 30 years. We do know that interferon is a safe drug in special situations like pregnancy. We know that it can cause problems, as people will be aware, in terms of low mood or thyroid dysfunction or some dysfunction in the liver, but generally is a safe drug to take. We don't have, thousands of patients who've been on the drug for 30 years. So we can't say for definite, but certainly there are no early signs that worry us.
And then similarly, there's a question on the long-term efficacy of hydroxyurea and safety.
Do you want me to do that one? Or?
Yeah.
So I suppose there was anecdotal data from many, many years ago that patients with MPNs who were treated with hydrea had an increased risk of developing acute leukemia. Now, there is a small but not insignificant chance of patients with MPN developing acute leukemia anyway, but this did appear to be increased in patients on hydrea. But when you pull that data apart, those patients had been previously treated with medications that we know to cause leukemia, things like radioactive phosphorus or busulfan. So we feel that this is probably a cumulative effect of these drugs as opposed to the hydrea. We have data from patients who don't have MPN, who have been treated with hydrea, particularly in a sickle cell group, and they do not have an increased risk of leukemia. So I suppose we do not feel that there is a significant increase there, and that it is safe to use hydrea. Evelyn, have you anything to add?
Yeah, and there was a fantastic study from Sweden. I mean, Sweden,
studies, yeah.
They capture everything from birth to death, and they had very good data in terms of looking at long-term effects of all the treatments, and actually it was from that population that the data from the infection also came from. I guess then there's a question about new promising medications coming up, and again, I think you've answered that. I mean, there does seem that there are a lot of drugs coming down the pipeline. The difficulty is that it takes quite a long time from medications being in clinical trials to them being approved and available for general use. And I would say there's quite a lot of the medications that Clodagh mentioned that it probably will be 3 to 4 years before we see in practice. I suppose the most encouraging thing from our perspective is it's such an active area of research. There are so many new drugs coming that there is almost certainly going to be some really good new treatments out there. But it is frustrating that it does take such a long time. Any thoughts on that, Clodagh?
No, I suppose it's an exciting time for MPNs, isn't it? You know, there is a huge amount of research and development, so I think the future looks promising.
There was a question about CBD oil for a chronically painful foot, and is there a knowledge base that we can access for non-traditional medicines, and the benefits of CBD as opposed to aspirin?
Do you want me to take that one?
Yeah.
So I suppose every decision we make in medicine has to be evidence-based. So we have to know that we're doing the correct thing, and we don't have data on CBD. We do have data that aspirin is beneficial in MPN patients, and that's where our medical advice comes from. So there have not been large randomized control trials looking at aspirin versus CBD. So I suppose we can't say that CBD is better than aspirin. We can certainly say that aspirin is beneficial and would be standard of care. Again, you know, I think sometimes certain non-prescribed medications may make people feel better, and if that works and it doesn't interact with anything, I think that's great. But I can't recommend things unless I have evidence to support their use.
Okay. There was quite an interesting question from somebody on the panel today about the effectiveness of a Chinese herbal medicine, ZT55, and this drug is thought to inhibit the mutant form of JAK2, and as far as I'm aware, there has just been that original publication in 2019, and I haven't seen anything further in the published press. I mean, I suppose you know, when we get medicines that are kind of get as far as clinical trials, they have already probably been 10 to 15 years in the preclinical arena before they get as far as a clinical trial. So the likelihood is that drugs like or supplements like ZT55 will be in that part of the pathway. And, you know, there are so many things that go into that part of the pathway that never make it out the other end. You know, there's probably 1,000 drugs that will be screened, and of the 1,000 drugs, there might only be 10 that actually look like they're legitimate, you know, that are clinically useful. And of the 10 that go into clinical trials, you know, you'd be lucky if you get 2 to 3 that actually really make a difference. So it is very frustrating at the pace of the research, but I mean, obviously, safety is the most important thing, and obviously the drugs have to be safe and they have to work. And there's a query about hydrea and skin side effects, and that unfortunately is one of the known side effects of hydrea, that they can cause both ulcers and other kind of irritation of the skin. Sometimes seeing a dermatologist can be helpful in terms of other advice. And then the other thing that people need to be careful of when they're on hydrea is that it can make them a bit more prone to skin cancers. So in terms of making sure that people wear good sun factor, and if you have areas on the skin, you know, small little areas that just don't heal, it's worth bringing them to either your GPs or the hematologist's attention so that they can make sure that they're not, and often they're precancerous. So if they're attended to early, they're not, they can be dealt with. Is there any connection between increased side effects, hydrea side effects, and having had the Pfizer vaccines? Not that I'm aware of. I don't think there was anything. I don't think there has been anything of that. Are there any new medications that have been introduced that help with the skin itching? I think Maz has very helpfully put up the link on the MPN information on managing skin itching. And pruritus can be, or itching can be a really frustrating symptom for people who have polycythemia in particular. If it's a symptom that doesn't improve despite all of the usual kind of advice in terms of showers and creams, ruxolitinib or Jakavi can sometimes be helpful, and that sometimes it would be worth talking to your hematologist. Clodagh, any thoughts on that?
Yeah, exactly. I'd say exactly the same.
Yeah, okay. Weight gain after ruxolitinib, do you want to?
So this is really tricky. Obviously, so ruxolitinib or Jakavi is a drug primarily used for myelofibrosis, and often patients with myelofibrosis can be very what's called cachectic, or have a very significant amount of weight loss. So weight gain can be beneficial for some patients, but it can tip the other way as well. Now, ruxolitinib actually raises something called leptin in your blood, which is a hormone that stimulates your appetite. So that's the mechanism by which people gain weight, is because this hormone is stimulated. So it is very tricky, and it's about recognizing it as a problem. It's about trying to portion control, because appetite is stimulated, so you're hungrier, so you eat more. It's a vicious circle. I have used, weight loss medication in some patients who have had, very significant weight gain with ruxolitinib, so that can potentially be an option. But I would suggest things like simple portion control, meal planning, maybe a dietitian review, and kind of last ditch effort is weight loss medication.
Okay, there's a question about allele burden and what's its significance. Do you want to take that one?
Sure. So when we say somebody is JAK2 positive or CAL-OR positive, that's when we have been able to detect the presence of a mutation in somebody's blood. But we can do something else called an allele burden, which is measuring actually how much of that mutation is there. And that is something that is used quite a bit in clinical trial, but it is not something that is in standard clinical use. It generally does not give us valuable information that help us tailor treatment or change treatment. So it's not something that we use on a day-to-day basis, and it's predominantly used for clinical trial purposes alone. Some medications, particularly something like interferon, can significantly reduce the allele burden, which is interesting, but again, does not really change the day-to-day management for an individual's care. So, as I said, not really in standard clinical use, nor likely to be really.
Thank you. There's an interesting question from about platelets. So people with ET have too many platelets, but do the platelets still function correctly? Or are they abnormal or malformed, and are there tests to check this? So actually that is a very interesting question. So most people with myeloproliferative disorders are more prone to develop blood clots, but there are some people who are more vulnerable to have bleeding, and that particularly happens often when patients are diagnosed initially, and their platelet counts can be very high. So sometimes people will tell us that they bruise very easily, or they have some extra nosebleeds that they used to have in the past. So there are blood tests that we can do to sometimes see whether people have acquired a bleeding phenotype, and it is a symptom that is important to tell your doctor. So if you notice that you're having more bleeding than you would have had normally, it is important to mention. For most people, we don't actually find that there is an increased in the blood tests. We can't define the bleeding risk, but it's really only in a relatively small group of patients that we see this. There were also a couple of questions on the chat. Again, I think there was quite an interesting question about. Do you want
to have a look there, Eibhlin, and I can answer the question in relation to maybe coffee and alcohol.
Yeah.
So there was a question from a PV patient in terms of the impact of moderate alcohol on hematocrit and whether decaffeinated coffee is okay, or should they avoid any type of coffee. And this person wanted to know if we could possibly say that, for example, 2 glasses of wine increases your hematocrit by X amount. So I thought this was a really interesting question and a real kind of question of the times. So the answer is we don't know, and it's different for every single patient. So I suppose there isn't a huge link between alcohol and increasing your hematocrit. There is a huge link between oral iron supplementation or taking lots of iron-rich foods and elevating your hematocrit quite dangerously or precipitously. What we would recommend is that alcohol is okay in moderation. I think that's the key. You know, you cannot say that a pint of stout or a glass of wine is going to increment your hematocrit, and says the body doesn't work that way. And particularly for PV, it can be incredibly unpredictable. So patients can go through periods of time when their bone marrow is very what we call proliferative for some reason, and then settles down again. And for some patients, the amount of venesections can be quite unpredictable, and blood counts need to be monitored reasonably closely. So unfortunately, our bodies are not, don't behave exactly as we would like them to all the time. So there is an element of unpredictability, but I would certainly say that there is no good evidence to say that caffeinated or decaffeinated coffee is better for you. in terms of your hematocrit, and that it is okay, once alcohol doesn't interact with any of your medication, to take it in moderation. Eibhlin, have you anything to?
Yeah, no, the one thing that I would like to reiterate there is that to make sure if you're taking multivitamins or supplements,
No iron.
don't have iron containing in them. You know, sometimes people whose hemoglobin has been incredibly well controlled for a long period of time come back to clinic and their hemoglobin has jumped up about 2 or 3 grams. And then when we chat through it, it emerges that they've just started to take a new multivitamin that has iron. So if you are taking vitamins, make sure that they don't contain iron, and you can just check with the pharmacist. There's a question about any evidence of a hereditary link in myeloproliferative disorders. I guess yourself and somebody else in the family have ET. And again, that's a very interesting question. We do know that people who have a myeloproliferative neoplasm are more likely to have another family member who has a myeloproliferative disorder. How that happens is not entirely clear. So you will find in some families that there are 2 or 3 direct family members, like a brother and a sister, or a brother and a mother and a son. But more commonly, it's cousins, or when you look at the population in general, there are family members. So there's 2 possibilities. The first is coming back to the MOSAICC study, the epidemiology study. So obviously, if you grow up in a family, you might be exposed to something that made you more likely to get the myeloproliferative disorder, and equally could have made your family member. And then the other thing is that there is genetic links. It doesn't seem to be as simple as I have the JAK2 mutation, therefore my son or daughter has the JAK2 mutation. It doesn't seem to be a direct link. And the other fascinating piece of research that came out earlier this year was at looking at what stage in our lives, if people have mutations, at what stage do they develop it? And actually, it may look like that we actually acquire the initial cells with the JAK2 mutation when we are in utero. So when we weren't yet born, that this abnormality first appears. So, you know, that I think was an incredible piece of science, and certainly will be something that we'll need to follow up over the next couple of years. Any thoughts on that, Clodagh, or the hereditary aspect?
No, I suppose Adam Mead in Oxford has done a large, well, is in the process of doing a study looking at potential family members with MPN. So I think that'll be interesting when the data comes out from that. But again, it's not, we certainly would not recommend that family members are screened once a patient is diagnosed. So I would never do a blood test on children of a patient or siblings as a screening tool. It's not useful, and it just generates anxiety. No, are we stuck for time?
We are a little stuck for time. We could go on. It's all such interesting. All the questions are so interesting. We could go on for a bit of time, but we are actually going to have to stop now. Thank you both so much. I hope you all agree this has been the most amazing forum. It seems to have gone incredibly quickly. And then once again, I'd like to thank the clinicians who've given up their time on a Saturday to do this for us. And also for Angela Thompson, who joined one of the breakout groups. She's a clinical nurse specialist from here in the UK. You know, we are so dependent on the community for ongoing support. And this connection with Dublin, with Cork, with Galway means an awful lot to us. And I would like to also to thank the people the support we've had from Novartis Ireland in putting this on. It's been an amazing forum. We would dearly love to get your feedback, because we are constantly trying to update and improve these online forums. But my final word is just to say, stay safe. We've got COVID-19, which still hasn't gone away. And we really, really look forward to seeing you in Galway on May the 21st next year. And thank you all for all your support.